Excellencies, esteemed colleagues, distinguished guests, it is my honor to extend a warm welcome to all of you. In cooperation with the National Organization for Prevention and Addiction Treatment, EOPAE, we are pleased to organize this side event co-sponsored by the permanent missions of the Kingdom of the Netherlands and Malta. Our focus today is a matter of global significance, harm reduction. I extend my sincere gratitude to EOPAE and our co-sponsors for the invaluable support in making this event possible. The theme of our discussion, redefining harm reduction, a need for a holistic approach, reflects the evolving challenges of substance use. Addressing its complexities, requires a comprehensive, people-centered strategy that moves beyond conventional approaches. This session will explore diverse harm reduction policies, emphasizing in evidence-based interventions that foster inclusive environments. Key areas of focus include drug consumption rooms, naloxone distribution, disease prevention, outreach, primary healthcare, housing, nutrition, and psychological support. Integrating these services not only reduces harm, but also strengthens rehabilitation pathways. We will also discuss innovative models, such as the one-stop shop approach, which consolidates services to improve accessibility. By sharing best practices, we can redefine global strategies and ensure harm reduction measures that uphold human dignity and well-being. Now, more than ever, redefining harm reduction is essential to addressing the physical, mental, and social dimensions of addiction. Through collaboration, we can advance a more human, evidence-based future. We are privileged to have with us today Mr. Athanasios Theocharis, National Coordinator for Addictions and President of EOPAE, who will introduce our distinguished panelists and moderate our discussion. Thank you for joining us for this important dialogue. I now pass the floor on to him. Thank you.
Thank you, dear Ambassador. Thank you for hosting. Thank you for the support that you give to us as Greece to present a model that we have and to have this beautiful discussion, I hope so, with my colleagues from the field. As you said, we have with us Mrs. Schiffer. Catherine Schiffer is known, I think, to the field, and she is Director of Correlation. And we have Mr. Koels, who is from Trimbos Institute from the Netherlands, and we have Dr. Vella from Malta. We would like also to thank the two the Kingdom of Netherlands, the mission of the Kingdom of Netherlands, and the Kingdom of the mission of the Malta that are sponsorship this event. So, starting from our point from Greece, we would like to showcase the model of Greece and okay. So we would like just to pick up some details and some point of our transformation in harm reduction through the years. In the past, harm reduction was about distributing of syringes and safe use materials, and especially in specific cities in specific areas such as Athens or Thessaloniki, and also in order to prevent the contagious diseases like HIV or HCV. Today, as the year passed, harm reduction services include more and more things, and they are provided by a direct access network, which is covering all the spectrum of people needs. New facilities and services have come and have redefined the harm reduction in Greece, such as drug consumption rooms, mobile units, primary healthcare units, day centers, shelters, naloxone programs, EU programs like Escape, and we will tell about that. And all this combination of services are provided in order to cover the needs of people who are facing addictions, and in a more holistic manner, and setting people into the center and providing direct access. So today in Greece, we have street work action, we have mobile units, we have the DCRs, mobile and stables, we have mobile methadone units. We have recently decided about the naloxone distribution programs with take-home and peer-to-peer naloxone programs, as well as we have primary healthcare units and mobile hygiene care units for people who are on the field. And respecting the housing problems, we have day centers and shelters. And a new project that we have with, in cooperation with the EUDA is the ESCAPE project, the searing residue analysis that we do from specific cities. So here you can see Greece. You can see all the new facilities that we have now. As you can see, Athens is in the middle of the country, but you can see that we have spread all the services around the country. So we have mobile units and day centers, as I told you, in many places, in Crete, in Peloponnese, in Thessaloniki. We have streetwear actions. We have 3 day centers in Thessaloniki and 2 shelters. And there we have a new mobile DCR, which is functioning for the last 4 months. We have mobile units in Thrace, the northern part of Greece. And of course, in Athens, we have the headquarters of harm reduction, where we have all the street work and the drug consumption, the mobile units for methadone and hygiene care, the shelters, the drug checking, and everything there. If you count these facilities, they are in 70 cities, 44 facilities for harm reduction. This is something that it was not a reality. It was not a situation some years ago. So here you can see the DCR facilities. You can see the mobile DCR that we have in Thessaloniki, the drug checking, the naloxone that we have. We have peer-to-peer and take-home naloxone programs, and we have the stable DCR fully equipped and very good, very well equipped with people, professionals. Here you can see the street work actions that we do in several places, in several points of Athens. We have put the new entry, as you see, here is the pipe of for the use of crystal meth that we have an increase lately in Greece. This was not something that we had in the past. We have it since, I think, 2.5 years. Here are the housing facilities, shelters, day centers, all the care that they would need, medicinal or nursing or social issues that they can give support to people who are coming to our facilities. And here is just 1 year with some data. Let's see, for all these services that we've done in 2024, we had more than 43,000 visits for supervised drug use in the stable and in the mobile DCR. We have a unique number for the syringe distribution, which is 1,300,000 the last year, which is surpassing the WHO average, and much more. We have, as I told you, the non-injecting kits that we distribute, and they are more than 26,000 per year. We have saved 356 lives from overdose with naloxone within the DCRs or on the field. This is a unique contribution, and it's something very, let's say, it's priceless. It's something unique. We have supported the ESCAPE project. The ESCAPE project, as you know, it's a project that EUDA does, and we have more than 1,300 syringes analyzed from 5 cities all over Greece, different ports, urban cities, and provincial cities, which is giving us much more information about the use and the profile of the users that we have in all over Greece. The contacts that we have almost are more than 125,000, and we give primary healthcare services to more than 8,000 people. And we have a new entry that we started covering their needs for meal distribution, that we have given more than 140,000 meals. So, and in the day centers, as you can see, that we have around 500 people every day that they are coming for every need that they have, for psychosocial support, for healthcare support, for connection, for referrals, for everything, and 170 people that are staying in the shelters every day. So this is a very different approach that we have implemented the late years. This is a holistic approach, and it's a very people-centered approach, very compassionate, and very and covering many needs of the people who are in need in the field. So we have tried to have a one-stop shop approach in every facility that we have, and to ensure the access to everyone. This model, by the data that you saw before, really works. And this is something that we want to showcase. We have evidence-based data in order to support it, and we want other countries to follow this approach. We have to showcase that when we have evidence-based data, we can support our work. Harm reduction is care and support. It is very essential to adopt this holistic and people-centered approach that promotes access to everyone and covers the full spectrum of all these people who are in need. We would like to share with you this, and you are always welcome to visit our country and see the premises, see the facilities, see the services that we have, see the professionals, how they work, and how they offer to people their real help and support. This is something that has changed not only their lives, this has changed our professionals' way of thinking, our professionals' way of working. Thank you very much, and we go to to Peter. Yep. Thank you.
Good afternoon, everyone. Thank you for the invitation to present on the experience with harm reduction in the Netherlands. I'm extremely delighted to contribute to this event. I represent the Dutch Trimbos Institute, which is the national knowledge center on mental health and addiction. And during this presentation, I will speak on a number of, let me see this one. Number of items. First, I will speak on harm reduction as an innovation and as mainstream. I will speak on what the current situation in Europe on harm reduction and some challenges that we have, and some options or perhaps some needs that we steps that we need to do over the next period. When starting this presentation, I realized that this is a very extraordinary moment. I've been working in harm reduction for a very long time. I've done numerous of presentations on harm reduction, and I always had to explain what harm reduction was and why it was needed. That's not necessary anymore. Everyone in the room knows what harm reduction is and why it is important. So this is a kind of an illustration that we've come a long way. And I noticed it in my own presentation. But it started in my country, in the Netherlands, as an innovation. It shows, for instance, two pictures. This from the 1980s. The first picture, the dark one, is from three brothers in a bridge in the south of the Netherlands. The other picture is a picture of a non-fatal overdose. In the middle of the streets in Amsterdam. Harm reduction started as a kind of an emergency public health response in the 1980s and then 90s in a number of countries, including in my country, in the Netherlands. And the most important item was to prioritize people above state interests and border control and convention agreements. The most important thing was to keep people alive, to give them the opportunity to stabilize and give them the opportunity for a decent and dignified life. That's how it started. But over time, it started with all kind of activities. Again, the three pictures, the picture of the woman and the man is actually the very first needle exchange syringe project ever in the world. It started in Amsterdam in 1983. The picture in the middle is graffiti. Is graffiti indicating that the organization and the address Binnenkamp 46 started with the distribution of clean syringes. And then the third picture is a methadone bus. It's a transformed public bus. And it is as low-key as it can get. It drove through the city and registered people who had a registration could get their methadone. And it was nearly brought to their community. That's how it started. But like I said, harm reduction has moved over all the years. Harm reduction has become part of the European drug strategy, of the current drug strategy. Harm reduction has become common language. Over there, you see the voting that happened last year. And the wording, after 30 years of advocacy and practice in numerous cities all over the world, it became not only scientifically accepted, but also common sense and universally accepted as the golden standard, as one of the elements that should be in part of drug policy, preventing drug use, treatment, but also harm reduction. So in a way, in many countries, harm reduction has progressed. But as you see, it also has a question mark. It looks like harm reduction has come a very long way. But we also could have, if we look at the daily reality in many countries, it might look a bit different, a bit more bleaker. I'm trying to maneuver to the next slide. And 2024, that's already a big challenge. We advanced 1 year. It's already 2025. We've got multiple challenges in Europe. There is decreases in funding for harm reduction. There is decreasing political support in municipalities, but also on local level. In my country, but also in other countries in Europe, the harm reduction is getting under pressure. Also because there are other priorities in our countries. Now, look at the world around us. Open a newspaper, and it goes from climate to biodiversity, a war at the edges of Europe. So there are all kinds of other, really pressing priorities, and there are urgent shifts in the global drug market and also in the European drug market. And I've illustrated this with a couple of pictures from the internet. Most of them are in. Now, one of them, for instance, is in Dutch. These are illustrations of how the drug market has changed. All of those elements didn't exist 10 years ago, 15 years ago. WhatsApp delivery, fentanyl, pain medications, the dark net, chemsex, laughing gas among youngsters. All of them are really actually quite new, and it keeps on evolving. I try to summarize it in a way: more synthetic substances, more digital access, and more, let's say, globally organized. Organized crime is way bigger in our current society, and the links and the disruption in communities also has advanced significantly. I think I often wonder, are our harm reduction services, are they answering these questions? And I think that they partly do, because they provide syringes, they provide opioid substitution treatment, they provide drug checking. But I think it would be good to, if we think on the longer term, if we think of a more holistic, that's the task, a more holistic approach, the task of this forum, I think that we also should look more ahead and start considering issues like safe supply, be more involved in decriminalization and regulation, and look at also include prevention of substances more carefully. I think there's also an item that harm reduction can link more in depth with all kind of mental health issues that, for instance, young people or young adolescents have, and that harm reduction should engage in these type of discussions. And lastly, I would encourage all of you, workers in harm reduction, people who are involved in policies for harm reduction, to engage in this security discussion. We cannot lock ourselves up, take care of people who are currently using drugs, and neglecting all the pressures that we see in neighborhoods where youngsters are being tempted or sometimes being forced into criminal activities. I think that we have the challenge and the obligation, actually, to engage in those type of discussions. So concluding, I would like to say that it's obvious that harm reduction is effective, that it works. It worked in my country, and it works in many countries all over in Europe and all over the world. And it's ready for a large-scale rollout. And at the same time, I think it's very important that it should indeed become more holistic and look at the challenges that our modern societies have. And that's get engaged in the discussion with mental and social vulnerabilities, and include a commitment into the crime and security discussions. So we've come a long way with harm reduction, but I think there's still a very long way to go. Thank you very much.
Thank you very much. It was very insightful, and on our part, we would like to thank you for the photos and all this historic review, which is very significant for to show us from where we were and where we are. So now we will pass through our next speaker, who is Dr. Vella. Dr. Vella is from Malta, and he's online.
Yes.
Dr. Vella,
Yes, I can hear you.
yeah, you can share your presentation.
Shall I share it myself, or would you prefer to share it yourself and I inform you when to go on to the next slide?
It's better for you. For you.
Share.
Share.
If I share it myself. So let me share it. I'm sharing it. Okay. So we'll go to this one. Sure. Let me post it. So can you see the monitor?
Not yet.
Where's my sharing? It should be on the screen.
Just a
Okay.
moment.
Can you see my presentation?
This is a field that harm reduction hasn't included the technology.
Digital
Yeah.
skills.
Yeah. We are only in the field, so
Yeah.
Yeah.
But we are very flexible, so we will adapt one way or another.
The only issue is that on my screen it is showing that I am sharing.
okay. We see your presentation now.
Very good. So, first and foremost, I would like to thank you for inviting us to this very fruitful discussion. Malta does indeed work and promote towards a harm reduction approach, and allow me to introduce to this presentation, apart from myself, Miss Dorian Tabona from SETA, which is the National Agency dealing with drug addictions in Malta. So initially, I will be delving into legislative amendments that have happened in recent years in Malta, leading up to the cannabis reform that took place in 2021, which eventually established the Authority for the Responsible Use of Cannabis, which today I head as the executive chairperson, and then my colleague Ms. Tabona will delve into further aspects relating to harm reduction practices adopted by Agencia SETA. So, why harm reduction? We believe that decades of strict police controls and punitive measures, included imprisonment, were not leading to a decrease in most drugs. In fact, it is very much known that the war on drugs had clearly failed. So, therefore, we had to reinvent a little bit the wheel and how we tackle drug addictions. With regards to cannabis, we could see both from local studies as well as from studies that have been circulated from notable institutions, both within the EU and internationally, that cannabis use was on the increase. And we believe that by not tackling this trend, it would lead to more harm. So in Malta, through the cannabis reform in 2021, the Maltese government, seeing that studies showed that a huge segment of the Maltese population made use of cannabis, rather than restricting such users to resort to the illicit market with all its risks and perils that it brings about, it would have been much more fruitful to regulate the sector and provide for licensed associations who provide quality controlled and quality tested cannabis to its users. So basically these associations, as I will be delving into further detail later on, they provide for cannabis and they tackle the process from seed to distribution themselves, and they conduct testing to ensure that the final cannabis product is not tainted with harmful contaminants that are usually found in products that are being sold in the illicit market, such as synthetic heavy metals, arsenic, and other aspects that can cause harm to individuals. But first and foremost, in the year 2015, the Maltese government took a legislative step to implement the Drug Dependence Treatment Not Imprisonment Act, whereby through the said act, the Maltese government wanted to look at drug use for personal use in a different manner. In fact, through the drug possession for personal use in stipulated amounts is not a criminal offense and thus subject to other administrative arrangements as determined by the Commissioner for Justice outside of the law courts. Therefore, if anyone is found to be in possession of small quantities of drugs, he will not be prosecuted before courts of law, but rather administrative arrangements would be determined by the Commissioner for Justice. And as the title of the law itself suggests, here the government wanted to introduce a system whereby we do not go after the individual to purely punish him, to put him into prison, to put him behind bars, but rather would look at that individual as a person who requires treatment and requires help and assistance rather than imprisonment. Indeed, specifically, the law stipulates that possession for personal use of up to 2 grams or up to 2 pills of any drug, irrespective of purity, is an offense punishable by a minimal fine rather than imprisonment, as obviously stated. In the case of a second offense for possession for personal use of any such drug within the period of 2 years, then that person would be requested to attend the Drug Offenders Rehabilitation Board, where an assessment of the situation is conducted for the purpose of assisting with his drug problem and whether the person is drug dependent. So here we see that we are having a different outlook towards users who consume drugs solely for personal use, where such individuals would require help, assistance, and treatment, and not imprisonment and social education. So the focus nowadays is on treatment and not imprisonment. Obviously, when we are speaking of instances where drug use is taking place for personal use. And this, we believe that it leads to the reduction of stigma and social exclusion. And therefore, that is why we believe that this initial law that was enacted in 2015 serves as an effective model of harm reduction. Then the second phase in 2021, notwithstanding the fact that there was the introduction of the Drug Dependence Treatment Not Imprisonment Act, we could see, and here we will be delving specifically into the realm of cannabis, we could see that cannabis was increasing in its use both locally and also internationally. And knowing that there was this increase in the use of cannabis, we believe that the government had 2 options, either to overlook or turn a blind eye to this problem, or rather introduce a system of regulation so that responsible cannabis users could have a safe space from within which to obtain quality controlled and quality cannabis that would reduce the harm. So therefore, they would be accessing cannabis that is definitely not tainted with harmful contaminants that are usually associated with the black market. So the focus was to shift these users from the risks and perils of the illicit market towards a safe and controlled environment. And when we speak of harm reduction in this aspect, it comes into different forms, whereby you have harm reduction in the form of physical and mental health, because if you have a product that is not contaminated with harmful contaminants, then that would reduce the harms and the risks associated with cannabis use. There is also harm reduction with respect to social and emotional factors, and also harm reduction in the sense that they would not be exposed to legal and judicial risks. So we believe that harm reduction is not a static concept, but rather a dynamic one and incorporating various themes. So, as I stated, in 2021, the Maltese government addressed these aspects by introducing a regulated supply chain for cannabis with the aim of fostering harm reduction. The main aim of the regulations and the reform was to ensure that users who voluntarily and consciously elect to make use of cannabis are provided with a safe and controlled space within which to obtain quality controlled and quality tested cannabis. The aim of the reform was not to promote or rather incentivize cannabis use. Indeed, several measures have been implemented to combat such phenomena. For example, licensed associations with the authority cannot do any form of marketing of their products, of their cannabis, of their stores, and access to cannabis is only allowed under a tightly regulated framework. For example, if you are a minor under the age of 18 years, you cannot become a member of such associations, and members of such associations cannot obtain more than 7 grams of cannabis per day and not more than 50 grams of cannabis per month. The reform also introduced the concept of home cultivation in order to further combat the illicit market, and indeed users may now cultivate up to 4 plants at home, but they may not retain more than 50 grams of dried cannabis. So here we are saying that this will only be allowed if it is to satisfy personal consumption. And obviously they may join an authority, as I have already explained. The associations are owned by the members, i.e. the users themselves, through a collective effort which prospers a sense of community. They operate on a not-for-profit basis and do not carry out any commercial activity. In fact, here we need to emphasize that the focus is on the aspect of harm reduction and not on commercial interests, because if associations would not operate on a not-for-profit basis, then their main aim would be to make more money, to generate more profit, and not to serve as an effective measure of harm reduction. Associations may only cultivate and retain the amount of cannabis required for their members following due approvals issued by the authority. There are the daily and monthly limits, as I have already explained, and so far they are only allowed to distribute dried flowers, but we will soon be amending our laws and directives in order to cater also for cannabis resin, because we are seeing that cannabis resin is also a form of cannabis that is wanted by users, and therefore, up till now, they are only having to resort to the illicit market. Given that this reform was intended to combat the illicit market, to serve as an effective measure in that regard, then it would make sense to also introduce cannabis resin under stricter conditions than dried flowers. So basically, that is...
Dr. Vella, sorry, you have 2 minutes.
Yes, now I will pass on the floor to my
Yeah.
colleague from SET in order to speak about the harm reduction initiatives undertaken from there.
Hi, everyone. So let me just, okay. So I'll be speaking about the harm reduction approach that Agencia SETA implements for its patients. One of the most prominent harm reduction strategies implemented by SETA is the opioid substitution therapy. This treatment involves the long-term prescription of opioid agonists such as methadone to individuals with opioid use disorders. These medications help prevent withdrawal symptoms and cravings and enabling users to lead more stable lives. Nowadays, we are seeing around 600 members every day. Additionally, it also helps people retain employment, maintain financial stability, and preserve relationships. And obviously, it also reduces criminal activity. Another valuable service offered by SET is the take-home methadone service. Although this is not suggested immediately because it also brings other risks, but it's a service which is provided to patients who have been stable and clean for a long time. Some of the key outcomes we aim to achieve through harm reduction and OST include a reduction in the prevalence of frequency of drug injecting, as well as decrease in sharing drug paraphernalia, a decrease in the incidence of infectious disease such as HIV and hepatitis C, a significant reduction in drug-related mortality, particularly from overdoses, and a decline in drug-related crime. OST also contributes to reducing high-risk sexual behaviors, improving health status, and enhancing social functioning, goals that extend beyond the immediate effects of OST. Since I have just a few more minutes, I will...
You have less than 1 minute because we have another one speaker. Sorry.
Okay. At Agencia SETA, we also have the addictions community team that take a comprehensive approach to harm reduction by providing a wide range of support services aimed at improving the well-being of both clients and their families. This includes educating clients, their significant others, service providers, and the general public through help calls and media interventions. The team offers one-to-one support sessions, urine monitoring plans, and relapse prevention strategies for clients who have achieved abstinence. Additionally, they provide harm reduction tips to minimize the negative effects of substance use and collaborate with clients referred by the Drug Offenders Rehabilitation Board to ensure a holistic approach to treatment. Thank you.
Thank you very much. And we would like to, sorry, but the time is pressing us, and we would like to pass to Katrin Schiffer. Katrin Schiffer is Director of Correlation, the European Harm Reduction Network, and she will have a critical view in general.
Yeah. First of all, welcome, and I really try to be short. I would like to thank everyone for inviting me. Everything has already been said, and I'm happy that actually John Peter was already providing a detailed definition on harm reduction. What I would like to do, except of being very critical, which is okay for me, is what we actually mean when we talk about holistic approaches. We can also say what is person-centered care and integrated care. And in principle, we should wonder why this is not something which is actually self-evident, because this should actually, all kind of care should be based on the needs of people who are getting this care. And I would also like to address shortly what kind of barriers are there to implement this. So, where is this? See. So I have not a real definition on harm reduction, and I will not read them out, but in principle, I think there are different things. What integrated means that you can, in principle, access different services at one place. I mean, you already mentioned the one-stop shop. Person-centered means that the person, the individual, is at the center of care and not, and I think this is happening very often, an existing system, because the system is like that. People have to follow the system and not themselves or a certain disease. And a holistic harm reduction approach acknowledges the individual and also acknowledges as well that very often other socioeconomic, legal history of people needs are actually contributing to a person who they are, and it's not only drug use. So here, the principles of harm reduction. I mean, when I'm maybe critical, I think John Peter said nowadays everyone knows what harm reduction is. I doubt it, because I think harm reduction, there are many misconceptions about harm reduction. Harm reduction is more than only providing needles, is more than only giving OST or providing a room where they can have a shower. I mean, it's harm reduction is compassionate. I think it goes for human rights, and it's non-judgmental. And we do not only say that because this means that we accept the choices of people, and that we also
harm
think.
reduction.
What? Oh. That we accept the choices of people, and also if these choices for us sometimes might be difficult. And we also think that everyone has the right to make own decisions. Yeah, harm reduction builds on evidence, on good practices, and most of all, and I think this is important, it builds on the communities we work for, and this is the people who use drugs, or people with lived and living experience. And I think this is something we should always keep in mind. It's not a top-down approach, but it is a kind of co-production. I want shortly to address some of the critical factors or the challenges why it seems to be so difficult to implement integrated, holistic, person-centered approaches. I think it's very often the narrow concept of health, that health is being seen as, for example, okay, you're a person who uses drugs, so drug use is your problem. We will provide you with OST. We will provide you, if you're happy with HIV, AIDS, and hepatitis C prevention, treatment, and care, and other kind of services. But there is not a lot of focus on all the underlying factors which might contribute to this. The prohibitionist and abstinence-based approach It's not only because it is contrary to what harm reduction stands for, but it also means that people who use drugs very often are not in the position to use services because they are using drugs. They are denied access to housing programs, they are denied services to mental health care, and many, many other services. And this is a problem, and this is, I would say, one of the biggest problems right now. Criminalization, meaning that people who use drugs are constantly living in a world and in their life where they or have to hide that they use drugs or that they are stigmatized and socially excluded. Stigmatization, misleading narratives on drug use. And I think there is a change also in many countries now that different stories are being told. In previous times, it was people who use drugs are criminals. Then it was people who use drugs are patients and we take care for them. And now it's more and more coming in different narratives that some people say people who use drugs are supporting crime, drug-related crime and organized crime, because otherwise all these cartels and organized crime would not be there. Another political challenge is that the people who use drugs are not involved in policy making. They are often not being heard. And if they are being heard, it often feels as a kind of cherry picking. Certain people are being selected, and it is not a real powerful mandate where they can also, that their input counts. And very often insufficient political support and funding for harm reduction. And I mean, being here now for 4 days, I think this is clearly what we can see, that the support for harm reduction is going down, that support for civil society is going down, and the support for all kinds of people who are diverse is going down. And this is something really concerning. Structural factors or challenges. This is fragmented funding streams. It's just an example. It doesn't need to be in every country the same, but I know that some countries there is local funding, there is national funding, but it can also be that some funding is from the health ministry, some funding comes from social ministry or for justice. So there is not a real coordinated approach. Bureaucratic and legal obstacles, inadequate monitoring and evaluation, and again, limited involvement of people who use drugs. Then we come to the organizations themselves. And so what we see is at local level, and you can probably check it in your own community, how is the organization being organized? Do you cooperate? Do harm reduction organizations cooperate with housing services? Do they cooperate with sex organizations working for sex workers? Do they coordinate their work with LGBTQI organizations? Mental health, all these things. But I think it's not only about the most obvious linkages, but there needs to be more cooperation, meaningful involvement. Patronizing care models, we already had it, where in principle the system is at the center. Restrictive legal and administrative frameworks, which make it very difficult for organization to be flexible and to actually respond to the needs, and funding instability. What people who use drugs are facing, I mean, this is stigma and discrimination, criminalization, and I think the rigid and abstinence-based care models. I don't go too much into detail and want to close with a number of things. Conclusions, I think political and financial support is needed. A drug policy reform is needed, away from punitive and abstinence-based models towards models which are built on harm reduction, social inclusion, and human rights. Stigma needs to be dismantled, and services need to center their work to the individuals they're working for. More cooperation, and again, meaningful involvement for people who use drugs. All this is actually in one of the in a publication we had. I don't know. It's I think from 23, which we published, and it's a summary from some of this work, not only, but you can find more information there. Otherwise, you can also contact me. Thanks.
Thank you, Catherine. I will keep the word of cooperation, which is a synonym to your organization names as well. So, in case someone has a question, something to...
Thank you, Mr. President. Some comments. Honorable representative of Permanent Mission of Greece in Vienna, distinguished speakers, on behalf of Ministry of Health of Greece, I would like to express my heartfelt congratulations to the President of Hellenic Organization of Prevention and Treatment Addiction, EOPAE, Mr. Theocharis, for his insightful intervention on the topic of the redefinition of harm reduction through a holistic approach. As Greece's national drug coordinator, Mrs. Theocharis plays a pivotal role in advancing a new strategy, one that goes beyond conventional medical intervention and embraces a holistic, socially sensitive, and scientifically grounded approach. As you understand from the presentation, Mr. Theocharis, Greece is fully committed to promoting a modern and multidimensional harm reduction strategy that includes prevention and early intervention, access to high-quality treatment, social reintegration, and respect and protection of human rights. If I want to express the speech of our representative, I will say 4 words: holistic, human-centered, dignity, and evidence-based policy. And a slogan: harm reduction beyond survival toward recovery. Thank you.
Thank you, Mr. Blue. Is anyone else wants to... Please.
Yeah, thank you for some very informative presentations. I have one question. I think it's mostly for the Greek description. Given the influx of migrants and refugees over the last decade or so, I was wondering, this holistic approach with housing and work and food and so on, how does it encompass migrants, refugees? And are there any barriers, like legal barriers or language barriers to helping these people?
Okay. Shall I start from Greece? Okay. Concerning Greece, I would have to tell you that there are specific programs for addiction treatment for immigrants, and we have access for all of these people. There's no, they are all included within the programs, and as well to the housing facilities that we have. There are, as you say, some barriers with the language sometimes, because there are too many languages that we have to face, but we try to have translation through specific NGOs that are specialized on this. And in general, I would have to say to you that there are no special increases to our population, meaning that our beneficiaries are not who are not local, who are not Greeks, and they are immigrants. They have not been increased through the late years because of all these that are happening through the continent. But we accept them as they are and trying to cover their needs.
Yeah, I want to shortly, because I have 2 hats, I can also talk on behalf of the organization which supports our network. which also has one drop-in which specifically works for European migrants, very often using drugs. And I think probably many people do not know that even in Europe, and even if there are EU citizens, that this group very often is also excluded from services. So even if they can access our service, which means they can access the drug consumption room, they can access the basic services, many other services will be denied. And this is healthcare services, these are mental health care services, these are housing services, these are also social reintegration or working services. So I think migrants are definitely, and then probably we need to talk about undocumented migrants, in a position which makes it difficult for them to access or integrated care or holistic approaches.
Okay. If there's no one else, we can finish this side event. I would like to thank you, all of you, each and every one of you, for coming here and listen to us. And in case you have any further clarification or question, we are willing to do so outside and help you. Thank you very much.